Welcome to Trigger Points Masterclass. In this video, we're going to walk through everything you need to know about trigger point therapy. You'll learn how to find the muscles and locate the trigger points before applying each technique step by step. All of this is free and it's the result of many years of practice and experience. Feel free to save this video and come back to it whenever you need. You can also use the timestamps in the description to jump directly to the trigger point treatment you're interested in. All we ask in return is that you share this video, like it, and leave a comment below to let us know how this content is helping you.
Throughout the video, we will guide you step by step, identifying trigger points and applying effective pressure to inhibit pain efficiently. Let's get started. Why treat these trigger points? True sciatica is often confused with that generated by trigger points. Obviously, in cases of sciatica generated by trigger points in the gluteus medius, minimus and piriformis, the symptoms of neuropathy are not present. Therefore, if the sciatica is due to trigger points, we do not have reflex alterations, for example, nor loss of strength, nor changes in feeling. We only have the typical pain radiation, which can be easily identified through trigger points. To locate these muscles, we first identify the iliac crest. We know this is the patient's iliac crest, and we also know that the gluteus medius originates from the iliac crest and inserts into the greater trochanter, while the gluteus minimus originates slightly lower than the gluteus medius, a bit deeper in the posterior iliac fossa. It inserts into the greater trochanter as well. Once we have identified the area between the iliac crest and the greater trochanter, we can establish our action zone. In this zone, we will have the gluteus medius and minimus. At this point, once the area is found, we can ask the patient to perform hip abduction, meaning to lift the leg. While resisting with one hand, we can palpate the contraction of the gluteus medius and minimus, because both of these muscles are abductors. At this stage, we ensure the patient is comfortable and use both fingers to locate the tense parts of these muscles. Once we find the tight area, which may correspond to the pain referred by the patient right at the moment of our palpation, we locate the tightest part that corresponds to the trigger point. Once we find the trigger point, as in this case, we ask the patient, is there radiation going down the leg? If the radiation is typical of the sciatica described by the patient, we can be fairly certain we have identified a trigger point for sciatica. We can choose to apply pressure on the trigger point in various ways, using our thumbs or fingers, and we maintain it for about 90 seconds or until we feel the muscle give under our fingers. After reducing the tension of the trigger point we found, we look for others, always in the gluteus medius and minimus group. The important thing is to stay in this area. Now we'll see how to locate the piriformis muscle. We will take reference points into account to accurately locate the piriformis muscle. These are the two dimples that clearly indicate S1 and S2. So from here, we draw the sacrum. Once the two superior posterior iliac spines have been identified, from the junction of the two spines, we locate the second sacral vertebra, which is S2. We know that the piriformis originates from the second, third, and fourth sacral vertebrae. It passes anteriorly through the sciatic foramen, joins, and reaches the upper part of the greater trochanter. If we want to actively locate the piriformis with the patient's muscle contraction, we flex the patient's knee and request that they move their heel inward. Now with this rotation, since the piriformis rotates externally with the hip extended, the piriformis will contract, and in this case, we'll feel the piriformis muscle fibers contracting under our hand. Now that the piriformis is engaged, feeling it well with the patient's muscle contraction, let's locate the trigger points. The most represented trigger points of the piriformis muscle are located at the origin and insertion, meaning in the sacrum and on the greater trochanter. How can we be even more precise? At this point, we have the patient perform another contraction, asking them to push their heel inward yet again, so we can better feel the muscle contraction beneath our hands. At this point, asking the patient for those contractions while we resist their inward heel push, we move our hand in contact with the piriformis along its path, where we feel the tightest part, that is, where we sense the greatest resistance beneath our hand. We get into a more comfortable position and concentrate all our force on that point, even applying double pressure with both thumbs, as you see here. This ischemic compression might cause the classic radiation sign, which can go to the popliteal fossa, or if we always focus on the tense area, that is, the exact trigger point, sometimes we may also observe some borderline fasciculation. It is very important to remember that while we perform this technique, and since the piriformis passes like a bridge over the sciatic nerve, we should be cautious that the patient does not report any significant paresthesia, because at that stage we could have made the sciatic nerve more sensitive. It is important to note that this last occurrence is quite rare, as in most cases the patient will experience radiation solely from the treatment of trigger points and nothing else. So in summary, this treatment consists of the location of the trigger point and applying direct pressure to inhibit it. The patient must be in a comfortable position to ensure the affected muscle is relaxed. We identify and locate the trigger point with flat palpation using our thumb. We apply pressure gradually, steadily, and slowly to the trigger point until we detect the first palpable barrier. We maintain the pressure until we feel a softening of the trigger point. The wait can be seconds or minutes. We repeat the action, increasing pressure on the trigger point until we find a subsequent barrier, and so forth. After maintaining ischemic compression for about 30 seconds, it will feel almost like a slow progressive settling of the muscle, which causes the hand to sink slowly downward. At that point, we release and then increase the pressure on the trigger point until we find a successive barrier, and we repeat until we feel a density that is almost normal under our fingers. At that moment, we move to another trigger point and repeat the same treatment. Remember to subscribe to the channel, like the video, and leave your comments below. Furthermore, check the link in the description to explore our courses and further your knowledge and skills. We'll guide you through the treatment for trapezius contractures using trigger point techniques step by step, the upper, middle, and bottom. Let's go. We will begin with the description and anatomy of the trapezius muscle, because this is very important for us to apply the techniques correctly later. The trapezius muscle originates from different places. The first is at the occipital bone on this horizontal line. Another origin is located at the C7 vertebra and covers all vertebrae up to D12, which is located right here. Its insertions are the lateral fibers and the upper fibers in the clavicular section, the middle fibers at the scapular spine, and the lower fibers at the bottom of the scapula. Now, let's identify the anatomical reference points. The reference points are, as we said, C7, which we can find by performing flexion-extension mobilizations, where the C7 vertebra goes forward. From here we can do another test to see if it rotates with respect to the D1 vertebra, making rotational movements of the head, as you can see. As it moves, we see that this identified vertebra is C7, because if it were D1, it obviously wouldn't move. Concerning the lower part of all vertebral insertions, down to D12 we locate it by tracing the lower rib margin of the 12th thoracic rib. Next, we locate the scapular spine by following the medial margin and going upward. We observe a depression here. This is the scapular spine, extending to the area near the acromioclavicular joint. Note that the trapezius muscle is mainly innervated by the accessory nerve, the 11th cranial nerve. Next, we will examine the movements in relation to the fibers. The elevation movement is provided by the upper fibers of the trapezius, the adduction movement of the scapulae provided by the middle fibers of the trapezius, and the lower fibers are responsible for scapular depression, as you can see. Now we will search for the trigger points of the upper fibers of the trapezius muscle. Our search should focus on finding the taut band, which indicates an abnormal state of tension in the muscle fiber. Practically at the top of the trapezius, we follow the muscle's path, and once we palpate the taut band, we can enhance our search by putting the trapezius under tension, slightly tilting the head, keeping in mind that the trapezius originates from the occipital area. Once we find the taut band, three situations may arise. Local pain may be present, or pain may radiate from the same point either upwards or downwards, and small fasciculations might appear visibly while staying in the same spot. After identifying the trigger point, we apply digital pressure to create a situation of low blood flow, or rather hypovascularization, which creates a relative ischemia. We keep the pressure for about a minute and a half, or until we feel the taut band release under our thumb. At this stage, the pain perceived by the patient decreases, and if there is any eventual fasciculation, it tends to disappear as well. The technique we just reviewed is a point pressure that helps us easily locate the taut band. The trapezius muscle is one that anatomically allows us to use a different grip as well, which is the pinching grip, enabling us to find and treat other trigger points also in the middle fibers, as we are doing now, carrying out nearly the same technique we just explained, but employing this different grip. Now we will execute the technique on the lower trapezius fibers. How do we engage the lower fibers? We request the patient to pull back both the shoulder and elbow so that a contraction is created that makes the entire margin of the trapezius stand out, as you can see, and thus also the lower part. At this point, we pinch the muscle in the lower branch and ask the patient to release the contraction to grasp the lower fibers of the trapezius this way, in this manner. Our objective is always to locate the taut band and discover, as we have seen before, the area of local or referred pain, according to the patient, or we can find fasciculations, as we have noted. At this stage, we perform the technique as we have seen before, maintaining this compression for approximately 90 seconds to deactivate the trigger point of the lower trapezius fibers. This will act on the pain perceived by the patient, which tends to decrease, and if any fasciculation happens, as we've said, it tends to go away as well. We can apply another technique. The one we just used is one, and this is another that involves accessing the deep fibers like this, which lets us find and address other trigger points as well. Don't forget to subscribe to our channel, like the video, and leave your comments below. Take a look at the link in the description to explore our courses and keep enhancing your skills. Description of the sternocleidomastoid muscle. By turning the patient's neck to the opposite side,
we can clearly see the sternocleidomastoid muscle bundle. This is the full bundle reaching the clavicle, originating from the mastoid part of the occipital bone. It looks good here. At this point, we will see where the trigger points are located. This bundle contains 4 trigger points located in this position. The stimulation of these triggers will create areas of radiation that vary in visibility. The first area of radiation is found right at the origin, that is, right here. Another area of radiation, when stimulating these triggers, will be the angle of the jaw. Another radiation zone is the side of the chin. Overall, it encompasses this entire area, with a more significant zone concentrated in the eyebrow, and it will extend down to the zygomatic bone area. Stimulating these triggers can also cause radiation in the parietal area and almost at the apex of the nape. We can treat these trigger points using ischemic compression, as usual. Since this area is more sensitive, we can adjust the compression technique by positioning ourselves laterally on the muscle and avoiding the front where the carotid artery is. There are 3 other trigger points in this area slightly anterior to the sternocleidomastoid. Stimulating these triggers can create radiation areas at the ear and back levels, but the area of greatest radiation is precisely at the auricular level. 2 other radiation zones are represented by 2 circles over the eyes. So by stimulating one of these 3 trigger points, we could have radiation zones up here and at the ear level. Let's describe the trapezius. The trapezius begins at the lower nuchal line of the occipital. These fibers descend and reach the acromion, clavicle, and scapular spine, and from here they descend to the D12 vertebra, inserting globally from the first cervical vertebra to the 12th. We can find the first trigger point with the patient seated in this area. Stimulating this trigger point may create radiation that rises to the back of the jaw and creates a radiation effect in this direction towards the temporal muscle. So this radiation practically circles around the ear. Another trigger point can be found with the patient in a prone position in this area. Stimulating this trigger point can generate an upward radiation in the homolateral area to this point, and it can also descend to the scapular spine. Thus, this is the route. One part goes up while the other goes down to the side of the scapular spine. Another trigger point is located about halfway. This is the point you see when you stimulate it. There can be radiation in the whole scapular region in this area, and radiation may also reach the back of the deltoid. Thus, we can see radiation in this area and another area when we stimulate this trigger point. There will be a zone of increased radiation in this area when we stimulate this trigger point. Another trigger point is found externally, and stimulating this point will give us very localized radiation in this area. The treatment always entails ischemic compression. We can also work by reinforcing the compression by overlapping the thumbs, and as always, we could maintain it for about 90 seconds to help deactivate these trigger points. We have 2 more trigger points. One is located in this part of the trapezius, and it has a specific radiation zone. The other point is found close to the scapula's tip, slightly more medial, and when stimulated it can generate radiation that follows the entire path of the trapezius. It will have a zone of increased radiation in this area. Please subscribe to the channel like the video and comment below. Check the link in the description for our courses. Let's describe the pectoralis major. There are 3 muscle heads. The first head begins at the clavicle and extends to the bicipital cavity. The second head starts at the sternum and goes to the bicipital cavity. The third head starts from the 1st to the 7th rib and always toward the bicipital cavity. Now let's see how we can identify the trigger points in relation to these 3 muscle heads. The first head's trigger points that reach the bicipital cavity are arranged this way. One is found here and the other is a bit lower. Here are the trigger points from the upper fibers that start at the clavicle, with the irradiation zone being the whole anterior deltoid area and medial. It involves the inner arm going to the inner forearm, where there will be a more evident irradiation zone. We will find the other trigger points for the 2 underlying muscle heads, that is, the one originating from the sternum and the one from the rib, that always converge at the bicipital cavity. Here, we will see the trigger points laid out like this. Overall, there are 5, 2 like this. The other 2 are positioned a bit more to the side, and the last one is lower. These trigger points can provide anterior deltoid irradiation and affect the medial part of the arm, extending to a more evident irradiation zone in the forearm. The treatment of the trigger points that gives us the best results is the one that involves local compression, which can be either single in relation to the patient's sensation or in overlap to increase the pressure. I keep this compression for approximately 90 seconds or until I sense the trigger release. During this compression, the irradiations we just mentioned may obviously occur. Pectoralis minor description. Originating from the coracoid process, which is this point you see earlier on the shoulder, and from this point 3 bundles branch out that attach to the 3rd, 4th and 5th ribs. The first trigger point is just under the coracoid process, and the other is descending diagonally, always in the 3rd bundle that reaches the 5th rib. These are the 2 main trigger points for the pectoralis minor, with the irradiation zone being the whole pectoral area, the shoulder, the medial arm, and the forearm, also involving the last 2 fingers and half of the middle finger. Thus, when treating the first or second trigger point we identified, we could produce irradiation in these areas we talked about, and there is a more obvious area of irradiation, which is this part of the anterior deltoid region. Remember to subscribe to the channel, give a thumbs up, and leave your comments below. Check the link in the description to see our courses.
Now I'm placing my hands on the so-called QL, which is the Quadratus lumborum. So it's the K12 area, the last rib, where we have the Quadratus lumborum, and we find its upper margin. We know that the Quadratus lumborum enters the first 4 lumbar vertebrae and the iliac crest, so in that area it will be easy to locate and palpate trigger points. Once we find the tooth band and the trigger point, I will make the ischemic compression. Of course, I will do the ischemic compression for the time needed to release the contracture. Let's now see the same technique on the Quadratus lumborum QL, and let's try to stretch it. Let's do just a little variation. Let's stretch it. Let's cross the legs. The iliac crest goes down, it gets further away from the 12th rib, and then our QL will be stretched. In this position, we lean on top of the patient and we do this ischemic compression. It's a very sensitive spot, so we need to be cautious and pay attention to the reaction of the patient. When it's better to use this position or the other one. So the one with the crossed leg is better, and we use it when we are dealing with patients who are very contracted and it seems like the iliac crest is right on top of the 12th rib. So it's almost impossible to touch it. So in this case, we prefer to cross the leg and stretch the QL because otherwise it would be untouchable. This is just a hot tip.
Please subscribe to our channel, like the video, and leave your comments below. Your feedback is crucial for us. Also, take a look at the link in the description to explore our courses and keep enhancing your knowledge and skills.
Here we have a supine patient. We tell the patient to turn the head towards one side and we expose all the anterior lateral neck. From the mastoid process, that is what I'm showing you at the moment, we find the beginning of the scum muscle, which is sternocleidomastoid muscle. With the finger, with the index, I'm following all the muscle. This is the sternal part of the scum. That is the part that goes all the way down to the sternum. During a contraction, the muscle comes out and we can see that the tendon goes all the way down to the sternum. I ask the patient to lift the head a little bit. It is a light movement is enough to show it. Let's now see the treatment of the scum muscle as well as the scalene muscles. The patient is supine. We ask the patient to make a flexion, a very gentle flexion to locate the scum. As we saw before, the palpatory anatomy is quite visible. Then we use a pinch grip, and with the pinch grip we grab the scum. It has to be comfortable, it doesn't need to be painful, even if this technique is always a little bit annoying and unpleasant. When with the pinch grip we have palpated the neck in order to find the trigger points and then the thought band. We will do the pinch grip to do this ischemic compression. Of course, we would have no possibility to push against anything hard. That's why we need to do this ischemic compression with the pinch grip. It is a quite long muscle, so we can decide where to work and where to palpate depending on where the thought band is. This ischemic compression can be held for several seconds, can be 30, 60, 90 seconds maximum. A reduction of the symptoms gives us a positive feedback of releasing a trigger point.
Please subscribe to our channel, like the video, and leave your comments below. Your feedback is crucial for us. Also, take a look at the link in the description to explore our courses and keep enhancing your knowledge and skills.
We will show you how to find and treat trigger points in the thigh, focusing on the rectus femoris, vastus intermedius, and vastus lateralis. As always, we will utilize ischemic compression, which by applying sustained pressure on the trigger point will reduce musculoskeletal pain almost immediately. Time to start. Quadriceps overview. This is the quadriceps muscle area. Let's look at the areas of the trigger points. There is one very important area near its insertion, here, where stimulating it can generate radiation in this direction. Let's say in the direction of the fibers, where it will have a much more significant radiation. Therefore, in this area, it will be more intense, and its radiation area is all of this area. If we want to find the rectus, let's have the patient perform a hip flexion so that it reaches under the hand. When we see the contraction, we will have identified the rectus to find the trigger point. Here is the vastus intermedius, but it concentrates there, not in the surrounding area of the trigger point. The vastus lateralis has its origin at the proximal third of the femur, let's say before the trochanter. It descends and merges with the other fascicles of the quadriceps. The trigger point zones are located here. The first area is approximately here. The second trigger point is located here. There's one just behind, roughly aligned with the second trigger point. After that, always going down in the vastus fascicle, we'll discover a trigger zone here and one a little more forward. How can we tell? The overall radiation related to the stimulation we provide will cover a much larger area of the muscle. It will be a fascicle that will reach from beneath the iliac crest. It radiates, and the largest area is represented by its fibers until reaching behind the popliteal fossa. As we know, we can stimulate like this, always using ischemic compression, suggesting a theory of about 90 seconds to reduce the potential radiation area of the trigger point and deactivate it. Don't forget to subscribe, like the video, and leave your comments down below. Review the link in the description to view our courses.
The tensor fasciae latae. How do we locate this muscle and how do we palpate it? So the tensor fasciae latae starts from the ACES, anterior superior iliac spine, going on the iliotibial tract and enter the Gerdi tubercle near the tibia. So this is the beginning where it starts, and then we see the iliotibial tract and all the way down to the tibia next to the Gerdi tubercle. We ask our patient to make a contraction. So first we ask to push with the knee towards the inside, and we see the bundles here under my left finger. This internal rotation is very useful because it makes us see the bundles very clearly. I'm asking the patient to do it again. It's also sort of flexion because the greater the contraction, the more the bundles come out. So once we locate it, we can do the palpation, always transversally compared to the bundles of the muscle. With the thumb or with the index, we can do this ischemic compression on the thought band or on the trigger points, and then here, as you can see with the thumbs. Once we feel that the muscles have relaxed, we can move on to another trigger point.
Please subscribe to our channel, like the video, and leave your comments below. Your feedback is crucial for us. Also, take a look at the link in the description to explore our courses and keep enhancing your knowledge and skills.
We place comfortably the arm of the patient and we go on the lateral side to locate the lateral epicondyle, where we know that we can find the extensors. Following a distal line, we can find the distal insertion of the long radial carpal extensor and the short radial carpal extensor. Now I'm showing you the brachioradial. It is a very easy muscle to locate, and by asking the patient to flex a bit the elbow in semi-prono supination, I can see it, and if I ask her instead to do an extension of the wrist, I can locate the long radial carpal extensor. Right under the long radial carpal extensor, we can find the short radial carpal extensor. Right after, we keep palpating transversely the muscle in order to find the thought bends and the trigger points. Now we are doing an ischemic compression in the long radial carpal extensor.
Please subscribe to our channel, like the video, and leave your comments below. Your feedback is crucial for us. Also, take a look at the link in the description to explore our courses and keep enhancing your knowledge and skills. In this video, we'll explain how to use trigger point techniques to effectively and professionally relieve pain from piriformis syndrome. Prepare yourself to elevate your skills to the next level. This is a problem that unfortunately very often affects many patients and can be a real challenge for both them and health professionals. Throughout the video, we will guide you step by step in precisely locating the piriformis muscle, identifying trigger points, and applying effective pressure to inhibit pain efficiently. This treatment is effective not just for piriformis syndrome, but for many other conditions involving the piriformis muscle. Well, let's get started. Now we'll see how to locate the piriformis muscle. We will take reference points into account to accurately locate the piriformis muscle. These are the two dimples that clearly indicate S1 and S2. So from here, we draw the sacrum. Once the two superior posterior iliac spines have been identified, from the junction of the two spines, we locate the second sacral vertebra, which is S2. We know that the piriformis originates from the second, third, and fourth sacral vertebrae. It passes anteriorly through the sciatic foramen, joins, and reaches the upper part of the greater trochanter. If we want to actively locate the piriformis with the patient's muscle contraction, we flex the patient's knee and request that they move their heel inward. Now with this rotation, since the piriformis rotates externally with the hip extended, the piriformis will contract, and in this case, we'll feel the piriformis muscle fibers contracting under our hand. Now that the piriformis is engaged, feeling it well with the patient's muscle contraction, let's locate the trigger points. The most represented trigger points of the piriformis muscle are located at the origin and insertion, meaning in the sacrum and on the greater trochanter. How can we be even more precise? At this point, we have the patient perform another contraction, asking them to push their heel inward yet again, so we can better feel the muscle contraction beneath our hands. At this point, asking the patient for those contractions while we resist their inward heel push, we move our hand in contact with the piriformis along its path, where we feel the tightest part, that is, where we sense the greatest resistance beneath our hand. We get into a more comfortable position and concentrate all our force on that point, even applying double pressure with both thumbs, as you see here. This ischemic compression might cause the classic radiation sign, which can go to the popliteal fossa, or if we always focus on the tense area, that is, the exact trigger point, sometimes we may also observe some borderline fasciculation. It is very important to remember that while we perform this technique, and since the piriformis passes like a bridge over the sciatic nerve, we should be cautious that the patient does not report any significant paresthesia, because at that stage we could have made the sciatic nerve more sensitive. It is important to note that this last occurrence is quite rare, as in most cases, the patient will experience radiation solely from the treatment of trigger points and nothing else. So, in summary, this treatment consists of the location of the trigger point and applying direct pressure to inhibit it. The patient must be in a comfortable position to ensure the affected muscle is relaxed. We identify and locate the trigger point with flat palpation using our thumb. We apply pressure gradually, steadily, and slowly to the trigger point until we detect the first palpable barrier. We maintain the pressure until we feel a softening of the trigger point. The wait can be seconds or minutes. We repeat the action, increasing pressure on the trigger point until we find a subsequent barrier, and so forth. After maintaining ischemic compression for about 30 seconds, it will feel almost like a slow progressive settling of the muscle, which causes the hand to sink slowly downward. At that point, we release and then increase the pressure on the trigger point until we find a successive barrier, and we repeat until we feel a density that is almost normal under our fingers. At that moment, we move to another trigger point and repeat the same treatment.
That's it for this Trigger Points Masterclass. I hope it helped you gain clarity and confidence in your manual therapy practice. Now, if you want to keep learning, click on the video thumbnails on the screen to explore more techniques and tutorials on manual therapy. Don't forget to like this video, share it with your colleagues, subscribe to the channel, and leave a comment below. Your feedback keeps us going and helps us create even better content. And before you go, check the link in the description to discover our complete video courses and take your skills to the next level. Thanks for watching and see you